My name is Rai. I use she, they pronouns, and I'm part of the community team here at Plume. I'm so excited to be closing off our All About You week with our very own co-founder, Jerrica Kirkley. And also, before we introduce Jerrica, I just wanted to give a little bit of info about Plume. Plume is the first digital healthcare company dedicated to the trans community. There are 4 trans people by trans people. More than half of the team is trans, and Plume is available in 33 different states and growing rapidly. Check out us at getplume.co. Lastly, I want to introduce Jerrica. So, Jerrica, if you would like, can you please tell us a bit about yourself, maybe even just about your gender journey, and how did you decide to start Plume, just so that people can get to know you?
Yeah, absolutely. Thanks, Ryan. Thanks, Alex, to both of you for helping put this on, and really fun to be able to do these. And thank you for everybody who's here today and listening. Yeah, I would love to share. I guess when I think about my gender journey, it's funny how a lot of it starts to come through in retrospect, later. But for me, I really started to think about my gender differently and understand that I'm trans a little bit later. It's probably a few years ago, like late 2018, early 2019, and in a more palpable sense, But then as that started to happen, of course, could start to think back in my early life and even sometimes as a kid, where it was like, whoa, okay, these were like moments that were very defining, but probably didn't recognize it quite at that time. And so yeah, but that for me, that was kind of when it started to happen. And it's interesting, my professional life and has been kind of intertwined in that for a long time. I've always worked, I've been working in gender affirming care for almost 10 years on some level. And even before that was working and a lot of my friends and community were just largely in the queer community. And so it's interesting, it's always been a part of my life in some way. And I guess that starts to make sense as I look back, even in college and other areas where I just always gravitated to that community. But at the time I could confirm it, like, oh yeah, I'm trans or queer or whatever it was. But I'd say like about 2 to 3 years ago, a little over 3 years ago, was when it really started to surface in a meaningful way. And for me, it was just like this initial moment of like, okay, I'm definitely not cisgender, and it was just like hit me like a ton of bricks. And and I was like, I need to figure this out. But it was just very clear, like that was not me. And it was funny, even before that, I had this other moment that I remember vividly, which is it's a little bit random but I just like had this moment. I was like, oh, I feel like a lesbian, and it's just like kind of a funny thing to say, but it was like
Yes.
literally before I even considered the idea of being trans, and even like had a lot of the language to say that. It just like that was a thought that popped into my head. So, which didn't make any sense at all in the context of like my life at that time. But yeah, and then really started to get in touch with, I think, who I of course really am. The progression for me, I was like, okay, I'm not cis, and so it really was like, all right, non-binary, where am I falling on that spectrum? And I don't know, some of you might relate to this. So I have like this pronoun progression where I was like, went from, he, him to he, they, to they, he, to they, to they, she, to she, they, and it kind of kept going. And as I got, further along, it just like really started to feel, what was right for me. And kind of falling into that feminine identity. And so on one level, it was like this amazing experience, of course, like this huge weight lifted up. It's like, this is who I am, after all these years, and started to explain a lot of things from my past. And as I always put it, just felt like I dealt with a lot of frustration and always like seeking something. That was my thing. I was like, oh, it's just like, got to get the next job, got to get the next, whatever it is, move somewhere, be in this location. And I was able to let go of all that. And it was just like instantaneously like, like this, I've found my place. And so that was all amazing, but there was also another side of it. There was a lot of chaos happening. I was navigating a relationship ending, family changes. Fortunately, work was incredibly receptive, and I had an amazing coming out experience at work. And it was a place I was working for at this point, almost 5 years. And so it was pretty intimidating to come out to suddenly like thousands of people at work in a big community health center where I was working at the time. But everybody was incredibly supportive. So I was really fortunate for that. And and so ironically, and it was, of course, you don't plan these things, but as that was happening, I've been doing gender affirming care for a long time. And I think always like trying to find ways to increase access, to make the experience feel better, to, overcome all these challenges that, of course, we work on a daily basis at Plume and the gender affirming care community broadly, and a lot of us face. And so always trying to think of a different way to do things. And even in my community health center, I was like, we really should be looking into virtual care. And again, this is like way pre-pandemic, because people just are driving like 5 to 6 hours to get to our clinic, and it doesn't make sense. But my co-founder, Matthew, who'd been working in digital health and looking at that kind of stuff, we were like, this makes perfect sense, so it just happened to align with me like coming out. And then we, shortly after that, within a few months, started the pilot of what now is Plume. And so, it's been an amazing journey to really be able to pair, I think, what I do professionally, of course, with my, my personal life, and find a lot of resonance in that. That's a little bit about my own story.
Oh, thank you so much, Jerrica, for starting us off with all of that. Yes, want to affirm the pronoun pipeline. I definitely had the same experience. And also just like wanted to really affirm the starting and kind of coming to your realization at a later age. Actually, a lot of folks that when people were submitting their questions, we had a lot of folks who were coming in asking if it was okay to be trans at a later age, or how is it to navigate even medically transitioning at a later age. And I also want to affirm that you can be trans at any age, and that is totally fine. And also wanted to pass that question to you, Jerrica. What do you think about it when people say, like, is there an age where it's too late? And also on a more clinical side, how does age affect the results of estrogen and hormone replacement therapy?
Yeah, it's a great question. I mean, so in terms of, of course, being trans, there's many ways to be trans, right? And it has to do with, of course, just our own internal sense of who we are, how we express ourselves. But there is, and for some of us, there can be a medical side, and obviously can be very helpful as well. So I think for the, everything that's non-medical, that really comes down to that individual, and of course having support structure is super helpful. So I think there's literally any age, but if we look at the kind of the medical side, the question is like, well, when am I too old to start hormones, for example? A lot of people want to know that. And similarly, there's no firm cutoff, and a lot of it comes down to, of course, individual circumstances, our individual health. I've taken care of folks who have started hormones from their teens all the way to their 60s. So it's a really broad spectrum. There are things that we take into consideration, of course, as we age, our bodies change in different ways, and we take that into account. But yeah, it's hard to say, like, pick a number to where, I don't think you're ever really too old. And there's many ways we can support in terms of expression, gender expression. Yeah.
Mm-hmm. Mm-hmm. Yeah, I kind of wanted to dig a little bit deeper on the more clinical kind of nitty gritty too. I think that just want to preface too that all bodies and all different types of people can and do have health problems just over the course in their life. And so this can be a question specifically about age, but I also want it to be opened up for all people who are facing with things like disabilities and health problems. Are there any kind of long-term effects on the heart, or can you take it after heart surgery? Do you have any information or any advice for people like that?
Yeah, this is certainly a question that comes up a lot, and I think when we talk about the category of heart disease broadly, and where there is increasingly more research going into, and when we say heart disease, there's a few things we talk about, so there's things like heart attacks, stroke, and blood clots tend to be those three categories that come up a lot. So generally speaking, estrogen is where a lot of that discussion gets centered around, but generally speaking, estrogen is very safe to take. Now, where a lot of the concern came from was actually looking at the effects of estrogen in cisgender females and cisgender women who were taking estrogen, usually, and we say like the post-menopausal phase of life, so a little bit later in life as hormones and their bodies are changing, and they're kind of taking estrogen as a replacement to help with some of the symptoms that can happen from estrogen levels dropping. So that's where a lot of that data comes from. Now, when we take a step back, it's like, okay, well, how much does that really translate over to cis trans folks taking estrogen? It's hard to know for sure, right? But it's clearly, different bodies, some different physiology, and it's probably not a one-to-one. And from the studies that they've extrapolated this information from, there's also just like acknowledging that a lot of the times the estrogen being used was not necessarily what we call bioidentical estrogen. So things like conjugated estrogen or Premarin, or horse, equine estrogens. And then for younger folks, we know that there's a link to things like blood clots for younger folks taking contraceptives or birth control pills, which is a different form of estrogen, again, not to get too technical, but called ethinyl estradiol. And so what we always prescribe with gender affirming care is or what we recommend anyways, is bioidentical estrogen. And so is there some risk? There's probably some linkages to elevated risk of some elements of those. But I think what I would love to see, and I think this is one of the questions that came up, is like, how do you see care evolving over the years? And something that we really want to try to contribute to the community from Plume is the more folks we can take care of and that we can provide access to, we can start to answer these questions on a much more finite level. So instead of extrapolating from other communities who are not trans, or looking at population studies over time, which don't take into consideration things like the type of estrogen being used or the dose, we can really start to understand better. So I always say there's never a firm contraindication, or meaning a firm reason to not provide estrogen specifically, even in the context of heart disease. But there are things that we can do to try to minimize the risk as much as we can, and it always comes down to a very individual conversation. Everybody feels different, about risk tolerance and that kind of thing. But there are things we can do. Just one example is patches have been shown. So estradiol patches have been shown to be safer compared to things like pills and injections in certain contexts when it comes to some of those risks. And so for folks who might have an elevated risk at baseline, that can be a good option potentially. So one example, but there's definitely ways to navigate it.
For sure. And we actually kind of talking about things around the differences in hormones. We actually just got a question that I'm very curious on too. This person had asked, should I stop taking hormone blockers to allow more physical changes to occur? And kind of on top of that, we had another question that was like, what is your opinion on cycles? What happens if you take a break, then come back?
Yeah, on the one is the hormone blocker, is that in the Q&A?
Yes.
Okay, yeah. Should I stop taking hormone blockers to allow more physical changes? So there's always, it's always important to understand, because like hormone blockers, a lot of people talk about them differently. There are what we call like puberty blockers, which we'll oftentimes use obviously in that puberty phase to block the development of an undesired puberty. Sometimes those medications can actually be useful later on in life too for gender affirming care. But then there's medications we use like spironolactone or finasteride, which block testosterone. So it can be helpful to distinguish those two, but in general, and it probably depends on your goals as well. So the contexts are pretty different, but for example, if somebody's taking puberty blockers, what we typically do, again, depending on the goals of the patient, would be to add on, for example, estrogen to encourage physical changes. Not sure if that's what the question was getting at, as opposed to just preventing things from happening. But for most adults, we're usually using estrogen as the main thing, and then adding in as needed testosterone blockers. Which, as it sounds like, helps block the effects of testosterone, but ultimately estrogen is what lowers testosterone in the body over time, or decreases the production. That was one of the questions that came up. So estrogen alone can encourage really a lot of the physical changes that do happen. I might need a bit more context on the question, but that's sort of those two scenarios. Yeah.
Sure, thank you for that. I kind of wanted to take a step back from something that you had mentioned in the previous question, which was thinking about what the future can look like for things like hormone replacement therapy and just like, yeah, the changes and evolutions in healthcare. I'm really curious to hear from you, like what changes do you think we'll see to care in the next few years, either with like new medications, delivery methods, therapies, etc.
Yeah, I think about it through so many different lenses. I think one is from a systems level, just how are we getting people into care? How are we providing care? Everything from, whether we're talking about physical access, the safety surrounding that, payment access, how we work as care teams, how we're helping patients navigate the system. So that's one bucket, which of course includes a lot of things in and of itself. And the way I see that evolving, I mean, really, I do think that, while there's always going to be a place for some physical care, right? There's things that we just can't, at least as of this moment, who knows what the future looks like, do in a virtual setting. But I do think we will see increasingly more virtual care, because I think we knew this for a long time, and right, that's why we wanted to do this, even before the pandemic came. But when it did come, I think it reiterated that for a lot of us, right? That, oh, actually, this is not only a nice thing to have when you can't go to the office, but it actually can just in and of itself be sometimes a preferred method to use, and maybe even do a bit of a better job than having to go through, the gauntlet of the physical infrastructure of the healthcare system. So I think that'll continue to move in that direction. And along with that, I mean, I think there'll be increasingly more developments that we can help facilitate virtual care and at-home care. Things like lab collection, right? It can be it's a core part of gender-affirming care and many care processes, but it's the technology to be able to collect all the labs we need in a home setting is still pretty new, and there's a lot of development that can happen. But I do think that will change a lot, where we can actually do a lot more, everything from monitoring to preventative stuff as well. That could be like cancer screenings, of course, things that extend beyond gender affirming care, or hormone therapy specifically, but even a lot of the preventative services that traditionally have been isolated to a physical facility. Within gender affirming hormone therapy, I'm very curious. I think on one level, I think we will see much better population-based healthcare, right? We're going to just have more consolidated centers of care. And I think what's encouraging is, of course, there is an increasing visibility of all of us as trans people. And as we create more affirming environments, more willingness to share that, we're trans and share our identities, which is really important, because we can't know the effects of things like medicines on trans people if we don't know who's trans, right? And that's been an issue for a long time, but that's starting to change. And so I think we will be able to better understand the risks of the medications we use. We'll better understand the effects, the good effects as well, and kind of, a better sense of maybe what timelines look like based on very specific doses. Also starting to understand the variability that occurs. Like we have observations where like, okay, well, we know some people don't suppress testosterone as well, but we can't truly explain why, And so I think we'll start to answer those questions, which can then help understand better therapeutic approaches too, to find ways to make sure goals are being met with treatment. In terms of like new medications, there definitely could be some things out there. It's interesting, like the medications we use now, we've been using for now almost 100 years. Hormones were first synthesized in the 1930s. And so they're kind of tried and true because they effectively reflect, what we produce naturally. So I think it is always like not to lose sight of the kind of keep it simple philosophy, because it works really well. But I think for those edge cases, we'll start to have some more tools. That's a quick snapshot. But yeah, I think it'll evolve on many lines. And I think ultimately the last thing I'll say is, like, of course, our goal is that we see, gender affirming healthcare in every sense of the word of healthcare, like everywhere, right? We're definitely trying to build this out with Plume, but that's kind of the dream and what I've dedicated my career to. I've taught everywhere on this, and so I think that from a cultural, societal level, of course, hope, and I do see that changing significantly over the next 5 to 10 years.
For sure. Yeah, I think a lot about for the future, at least in terms of what we are in presently, I think there's a lack of studies too that kind of contribute to the lack of information or experience that other providers who aren't trans competent or trans inclusive, they don't have access to a lot of information. So I'm really also excited to see as we begin to center more of ourselves and really just continue to focus in on our community. Like we have the 2022 like trans US survey that's coming out, and like the more that we get informed about the things that we go through and just like really diving into the studies of how these really impact our body, the better care we will continue to receive for ourselves. So yeah, also kind of attached to that, like do you know of any kind of, we had a question around is there any kind of anecdotal or like data driven evidence for the patient's experience with emotional or mental health and related to like hormone replacement therapy?
Yeah, there are actually. I don't have them right in front of me, but I know there are several studies that looked at gender-affirming surgery specifically and the impact on mental health outcomes, which in multiple that have reported improvement in mental health outcomes. And there's one a bit more recently looking at hormone therapy specifically as well, which also reported improved health outcomes with mental health. And so yeah, that, I mean, we are actually getting, to your point, like more structured data and studies supporting that. I think it's something that, of course, a lot of us have experienced on a personal level and anecdotally can say like, yes, this is helpful. But, when it comes to regulators and policy change, of course, it is nice to see it in writing for those that are making the rules. And so I think along with that, I guess that would be the other piece that I mentioned before, but I think there's the systems level of healthcare. There is the more nuanced kind of therapeutic level. There's a cultural, societal level, and then there's a policy level, right? And so I think that is something that actually, watching in front of my eyes very quickly evolving, which is exciting. Now it always takes time, but at Plume, we work on a lot of things, right? And we work on all those levels, which is really exciting. And but one of those things that we're really also pushing for is on a policy level to ensure that trans folks have access to care in the ways that feel good for them. And so as we're going around and talking, to things like Senate offices and committees, and there's been a really good reception, and I think folks are getting their eyes opened in a good way and understanding the need. Yeah.
For sure. Thank you for all of that. Wanted to bring it back to more of a clinical level, since we were just getting some more questions around that. One just recently came in, actually kind of on the subject of cycling, more specifically. This person was asking, a lot of people have talked about anecdotally about recommending cycling with progesterone. Do you have any thoughts around that?
Yeah. Thanks for reminding me. I forgot about the cycling part of that first question. Speaking to it more broadly, there isn't anything we can say that it's like a reason that you shouldn't do it. One thing to know about estrogen in particular, if you do cycle estrogen, there can be that sort of almost a withdrawal stage, and essentially kind of like a mini menopause, if you will, right? Because it's like as if you have estrogen levels maintained in the body and then they drop, you can experience things like hot flashes, mood changes, and general discomfort. Not dangerous. So that's important to know, so that if that feels right for you in terms of cycling on and off estrogen, certainly something that can be done, and nothing to support that it's dangerous in any way, but it could be uncomfortable in moments, depending on your levels and that kind of thing. From progesterone, I think progesterone tends to be pretty well tolerated. Similarly, I mean, we haven't seen any evidence to say that cycling progesterone or taking it and stopping it and taking it again is detrimental in any way. So yeah, I think it's totally fine to do it if that feels right. And there's not really, from a prescriptive standpoint, there's not like one way to do it, in terms of length of time on it. Now, with that being said, I haven't heard anything or seen anything that shows that cycling versus not cycling is more effective than, one's more effective than the other. And everybody's goals are of course different, but yeah, haven't seen a reason specifically not to do it. And I did see that. I'm happy to answer that question. I saw one pop into the chat here. It was similar to, I think, that previous question about hormone blockers, but somebody asked about stopping spiro or spironolactone, and how will it affect estrogen. And this is actually a really good question because this comes up a lot, because as the person in the chat noted, they might have had some other things going on in their body where the provider wanted to stop spironolactone because of some side effects. And that can happen. It affects your electrolytes. It's a diuretic, and so we do have to monitor that. But how will it affect estrogen levels? So this is a really interesting one. They've done studies and they've looked at folks taking estrogen or estradiol and spironolactone together and without spironolactone. And so really interestingly, on the folks, at least in the study that were taking them together, they had much more erratic and kind of disparate levels of estrogen compared to those that took just estrogen by itself. So that's something to take into consideration. Hard to know what that looks like across the board and for a lot of different people, because this was a fairly small study, but in one sense, taking spironolactone with estrogen might actually result in kind of more up and down levels. And so if you say, well, you pull away the spironolactone, it might actually stabilize out the estrogen levels. And so a bit of a trade-off, because spironolactone does have, can be helpful as well. But a lot of people say oh, is it going to shoot my estrogen back up? And it shouldn't in most cases. So partly depends on your dose of estrogen and how long you've been on estrogen. But spironolactone might have a little bit of effect in suppressing testosterone, but not a lot. Mostly it's just kind of blocking the effects of what's in the body. So for example, if you had a bunch of testosterone or any level of testosterone in the body and you take spironolactone, it's not going to necessarily change the level of testosterone, but it'll just change the effect on the body of testosterone. But as long as you're staying on estrogen, it should continue to suppress the testosterone levels. So again, in most cases, should not be a rebound. But everybody's a little bit individual, and it does depend on your dose and how long you've been on it. But yeah, typically there should not be a big rebound if you stop spiro.
Sure. Yeah, and also just wanted to kind of dive deeper on, right, there's the hormone blockers, there's estrogen, there's all of these different methods and dosages, and I know that it is very much personalized on an in individual person basis. How are the dosages and methods of delivery determined for patients?
Yeah, excellent question. So there's a few different methods we use, or uptake routes we say. Tablets would be one, and we generally recommend taking them sublingually, meaning let them dissolve under the tongue. Now, one important thing to note is that these are not specifically made as what we call sublingual tablets. but they're totally fine to take sublingually, and they work just the same, but they're marketed to be swallowed. So that can come up the pharmacy. And so we always, put on our prescriptions like, hey, we talked about sublingual, it's okay. Yeah, we got to bring everybody along on this journey, right? And then other ways, there's patches, as I mentioned, and there's injections. Those are the three primary methods. There are pellets. Now, pellets are little things that can go under the skin, and these are compounded, so they're kind of custom made. This isn't something you could just buy from a prescription to any pharmacy, and do require a procedure. So those have to be done in an in-person setting, not done as often. And the only way to change your dose is if you cut one out and put a new one or whatever it might be. So not super convenient. So we mainly use tablets, patches, and injections. As far as determining the dose, that's totally based on the individual's goals. And so we always, say that we don't treat a gender identity, we treat the person, and so recognizing that gender identity and gender expression, can be independent things and don't necessarily align in terms of what our expectations or, perceptions might be. And so what I always ask is, hey, we have various medications, and I always want to know, like, what's your journey look like for this? And do you want to start off slow? Are you looking to just get into it? What degree of physical change are you looking for? We talk about microdosing sometimes, which really is just taking a lower dose so that we move things along a little bit slower and maybe not to a extensive degree that a higher dose might offer. So that's like the most important part, is just exploring that together up front. And that's really what we focus on in that first visit, and with our kind of intake process and questions. But from there, then, we generally, having done this a long time, we kind of know what doses typically correspond to certain levels that we're trying to get. And then we, again, generally know how those levels typically correspond to physical change. And then we guide it based on individual progress and how folks are feeling.
Mm-hmm. Yeah, and I actually just saw a comment on the chat too, kind of talking about the degree of changes, like microdoses and the different dosages. A person in the chat said that their 27-year-old had an orchiectomy and has been on estrogen injections, but hasn't seen much breast growth and only some fat distribution. Can you say a little bit about like whether or not like genes affect how much change happens on your body?
Yeah, absolutely. It's another one of the first things that we talk about, when we're just kind of getting started. And even for folks that, like you said, have been on hormones maybe for a while, and they're having a conversation. But it is important to remember that, everybody's body is different, and a lot of these things, any development there's a lot of like predetermined genetics, essentially, right? And so there's genetics which sort of say like, okay, this is your set point, or this is like what your body can do and how it will change over time. And then there are the medications, which of course, help the body develop in a way that within those limits, based on hormones that, we didn't have before, or at least in those proportions. And so there is a reality that there's everybody's got, different developmental pathways. And I think and it's impossible to know up front, as of now, we don't have that technology to say like, this is what you're able to develop in terms of breast development, or this is, how your hair growth will evolve over time, or whatever it is. But we do, so sometimes it just takes time to understand that. And generally speaking, I'd say, we look at changes occurring anywhere from 2 to 5 years of being on hormones, right? So it always is important to look at, okay, how long have folks been on hormones, and also what have they been on? And again, what doses? Because I've had folks come to me who, haven't felt like they've been progressing in the way that they should, but they've also been on incredibly low doses for a long time, and so there is, it can actually be really helpful, even if you've been on hormones for a while, to maybe adjust your dose, or adjust the route, and again, I don't have a study to support this, but anecdotally, we've been seeing this much more, that that injections, and it probably has to do with the way that they peak, tend to bring about changes in a different way than tablets and patches do. Now, not for everybody, but for a lot of folks who are maybe having trouble suppressing their testosterone or just haven't seen the physical development that they would desire, switching over can be helpful. So a lot of factors there, but genetics is a big one for sure.
Mhm. For sure. And kind of talking in line with the beginning of that question around orchiectomy, somebody had asked, is that more helpful for E2?
Is orchiectomy more helpful? Is that?
Yeah.
Okay, let me read the question here.
It should be in the Q&A box by Gemma.
Okay, let's see. More helpful than Spiro. Oh, I see. Gotcha. Orchiectomy compared to Spiro. Yeah. It's so in orchiectomy, you're removing the organs which produce testosterone. So I'd say that is certainly probably the most surefire way to suppress testosterone, right? Spironolactone is blocking the effects of testosterone. But not necessarily removing or decreasing production of testosterone. Now, estrogen will actually decrease, or E2, or what we call estradiol as E2, will decrease the production of testosterone. So yeah, I'd say like orchiectomy or a surgical removal of those organs would be the most sure bet of keeping testosterone out of the body and keeping the levels low. Now, you will still produce some, right? There are other organs in your body, like your adrenal glands, for example, which could be producing some, but in very low levels. But yeah.
Awesome. Thank you for that. And thank you for the patience of like analyzing what the question was
Yeah, no,
too.
I love it. It's fun.
There's another general question around, and this is somebody that was submitted who was older. They said that they're transgender and over 50 years old. And 3 to 4 days after they inject, they notice that their mood goes downhill. Is there anything that they can do or take to help with that?
Yeah, that's a good question. There could be a few things going on. If it's an injection, you do have a peak in an injection. And in most cases, it's peaking at about 48 hours. So, that might correspond with a drop from that peak. And, so it's always important to look at the dose that you're on, talk to your provider about, your dose. And sometimes, it's interesting, you don't typically need like really high levels to, one, suppress testosterone, and two, encourage physical changes. And it doesn't take much. Like we traditionally did not measure estrogen levels. It was only in the last, I'd say like 4 to 5 years, maybe even more recent, that a lot of providers were starting to actually check estrogen levels more, estradiol levels specifically. And, what we're finding is it just doesn't take as much as I think we thought, and that we're in like the kind of old original guidelines that were out there in terms of dosing recommendations for injection. So it could be that it's peaking really high and you get that drop and you feel that drop. That's pretty common across the board. I'd say, whether you're injecting testosterone or estrogen, but just like that hormonal drop, it can definitely be felt. So yeah, always good to look at the dose. And there's a lot of other things we can consider. That is one of the advantages of things like sublingual tablets and patches, is that they do tend to have a bit more stable levels. And if you think about it, injections are going to peak the most, and then a sublingual tablet is going to peak not quite as much, and then a patch is going to peak not quite as much either. And then it'll be basically stable as long as they're consistently changed. You're muted, Ray.
Thank you. We had a question about sexual and genital function while starting E. Was there any risks in taking E, and is there anything that you can do to mitigate that?
Yeah, really good question. One that, of course, we always make sure we're discussing up front. And yeah, so taking estrogen again is going to suppress testosterone, and testosterone is the main driver, if you will, of things like erectile function, of production of the the physical components that are necessary for fertility. So as you lower testosterone, those things do typically decrease. So that's important to know. And it almost assuredly will happen as long as you're on estrogen, staying on it. Now, there is a dose dependency there, right? So it depends on how much you're taking, how quick, and that will determine how quickly those things get suppressed, and to what extent. But a lot of people ask, well, is it permanent? What if I take estrogen and then I stop it? Will those things return? So we do actually have a study that's looked at this, and it does appear that the longer you are out, if you were in that scenario where you actually stop taking estrogen after starting it, those levels rebound, so that all that kind of the function and the levels do tend to rebound to the levels they were at before starting estrogen. And they've looked at it, again, these are not, of course, like lifelong studies, but looked at folks who stopped estrogen for like 3 weeks, and I think up to about 6 weeks. And once they got to that 6-week mark, usually the levels had returned to kind of pre-hormone levels, if you will. So, and again, that can vary from individual to individual. So if that situation arises where maybe somebody's, considering pursuing fertility, and they want to make sure that their body's able to produce a sample that can do that, then to be safe, we usually advise at least like 8 weeks to 2 months off of estrogen and any testosterone blockers to be able to do that. But yeah, so the levels do generally return, of course, as long as you haven't had surgical removal. Now, if somebody's really concerned, and it's like, hey, I know that I want to have this capability, then we do always encourage to try to do some sort of specimen collection up front and freezing and storage of that genetic material so that it can be used later. So that can be done before you start hormones. But yeah, so we do have increasing evidence that it's certainly not a definite that if you start estrogen that you'll never be able to, have reproductive function or fertility.
Thank you for that. It looks like we're getting a good amount of questions around progesterone. So
Nice.
if you don't mind that we go back to that for a
Yeah.
second, there's this person who sent in the Q&A saying that there's lots of information that is starting to circulate around the use of progesterone, but not much around the bioidentical creams in particular. They had mentioned that they noticed the effects of cream, but not much in the way of guidelines and empirical data.
Yeah.
Do you have any kind of resources or more information about the differences between bioidentical creams versus the pills?
Yeah, really good question. So it's tricky. So unfortunately now we don't have a lot of information about creams. I was to say particularly progesterone creams, because most of the progesterone creams that are out there are either over the counter, and so it's kind of been produced through the supplement pathway, if you will, or they come from compounding pharmacies. and the downside of that, while they can be really accessible, the downside is they don't go through the same kind of validation process and FDA approval and studies. And so we just literally don't have the studies to say like the effectiveness of a cream versus an injection versus a pill. And I know usually progesterone is most widely available, and at least in a prescription format, as a capsule that you would take by mouth. So yeah, so unfortunately, like we don't have the side-by-side comparison. I mean, speaking anecdotally, I certainly have had patients who have taken both, and I think we can look at it from an effectiveness standpoint and from a safety standpoint. The safety is interesting. We're getting kind of conflicting evidence when we look at progesterone, again, because of a lot of these studies that I mentioned before that were looking at estrogen. They also looked at the effects of taking progesterone as well, again, in what's called the WHI study, or the Women's Health International study, and that was looking at a lot of cisgender women going through menopause. And through that, there is also this kind of potential linkage to heart disease with progesterone, right? So not nearly as much comes up as it does around estrogen, as we talked about before. But so that is a consideration. And so one part of that question was asking, is it safer to use like a topical cream versus a capsule? Excellent question. I don't think anybody could say today. Generally speaking, transdermal medications, and as we've seen in the case of estrogen, tend to be safer because you are like bypassing certain components of the body, like not going through the liver, for example, as if you were to swallow a pill or a capsule. So I think we could theorize it might be safer, but hard to say right now, unfortunately.
Mm-hmm. And kind of also going with the anecdotal route too, we had another question around what about pure maca for breast development? And what do you think about these more holistic types of ways of things like breast development?
Yeah. So, a lot of questions about supplements for things like breast development and feminizing changes in general. There are, there's definitely what we call phytoestrogens, right? These are plant-based estrogens. Soy, is the most common one that probably gets all the press, but there's other ones out there. So I think there's like legitimately, there are, plant-based, ultimately that's where a lot of this stuff comes from, but supplements that can encourage these feminizing changes, because what they ultimately do is lead to increased estrogen levels, right? And so I guess one question is like, okay, well, if the ultimate way of getting there is because we're increasing estrogen levels in the body, does it really make a difference in, at least like speaking from a safety standpoint, of whether that's coming from their own natural internal production or taking estrogen? And I think that's, again, a question that we just don't know. A lot of the safety stuff centers around the levels of estrogen in the body. And when they get to be really high, that tends to be the trigger point of when like, oh, okay, more events occur, as these levels get higher, is what we've seen, at least in some of these studies that are out there. From an effectiveness standpoint, it does largely kind of come down to the levels of estrogen in the body. So, if you were to take a supplement, I think it could be interesting to look at the impact of your estrogen levels in the body. And that would probably largely dictate in terms of how likely they were to contribute to things like breast development. So safe to say, I think there's a chance they can help, again, because they're supplements. We can't really speak to the safety of them. But I think if you're like, and it's always tricky depending on your access to care, but if you have, you are able to access taking estrogen, the nice thing about it is we can pinpoint bioidentical, look at your levels and that kind of thing to of course help ensure that you're progressing the way that feels right, and also look at safety. But yeah.
Mm-hmm. Mm-hmm. Yeah, and also kind of speaking about safety too, and I'm sure that this is a type of question that we had answered early on, but this person had asked, what are factors that make hormones more effective earlier in age versus 40? And also, for folks who do have health complications as seniors, are there any alternatives that exist for GAHT care?
Yeah, okay. So the first question, or the first part of it, what are things that might change the effectiveness of hormones, whether you start them earlier or later? One, part of it is just like exposure to other hormones. And so of course, an advantage or a potential advantage of starting them earlier, and even starting with puberty blockers and transitioning to things like estrogen, is that the body just hasn't been exposed for very long and to very high levels of things like testosterone, right? And so it just hasn't even had as much time to develop the changes that we generally are undesired and are trying to change. So just the longer that you go with higher levels of testosterone in the body, more of those changes occur. So it's kind of just changes your starting point, right? But in terms of the body's ability to develop, I think that one is, this is based on what I've seen with a lot of people over the last 10 years, really genetically based, because I've had folks who've started hormones in their, 30s or 40s and have experienced, what they feel like is, quite a bit of development, and folks who've also started younger, who, maybe subjectively don't feel like they've had as much. And so I do think that varies quite a bit. And again, probably gets back to that genetics conversation. But I think the main difference is just sort of the effects that have already occurred, and for some of those things can be harder to reverse, whether that's, scalp hair changes, things like facial hair growth, depending on when that's caught. Again, early on, puberty, mid-puberty, a lot easier to shut that down. So yeah, those are some examples, I guess. And then what was the second part of that question, Ray?
The second part was for seniors specifically who do have health complications.
Oh yeah.
Are there any kind of alternatives, or do you have any recommendations for them?
Yeah. So there can be some, kind of like we talked about at the beginning, it's always important to look at, of course, whatever health circumstances that are going on, and how we can risk modify even within estrogen, right? So that could be maybe going from tablets to patches. So there could be some options there, right? And if it's like, okay, well, if we don't feel like using estrogen is the right thing, maybe there are some medications such as, the testosterone blockers we talked about, right? Spironolactone, finasteride, that in and of themselves are, of course, blocking effects of testosterone, and can have sometimes result in some slightly increased estrogen levels. So those can be options. And then, it's always, I think, again, just depends on the circumstances, but can look at procedurally, right? And so if their person was still producing testosterone, and if something like an orchiectomy was an option, that can be one way. So bottom line, there can be options, and just depends on what those individual circumstances are.
For sure. Just wanted to do a little time check too. I think that we do have time for one more question. Just wanted to give you two options. Do you want something more clinical or something more reflective for yourself?
We can go clinical.
Okay, let's go.
That's what the people want to hear.
Yes, absolutely. There's one that was very specific, actually. This person said that they had started E in Spiral 3 months ago and was recently given a doctor's approval to updose from 4 milligrams to 6 milligrams on E daily. Is that a good pace to go? Should they take it a little slower?
Yeah, good question. And general disclaimer, of course, none of this is specific medical advice. More speaking generally, I'll always want to make sure you're discussing with your provider. But speaking on general practice, going from 4 to 6 is typically very, very reasonable. Of course, does depend on your individual progress and also your levels. But I would say quite commonly we, starting somewhere between 2 to 4 milligrams per day, certainly could go lower if that's the preference. And then the next step, if there is, room to go up and a desire to go up, is often from 4 to 6. So. Yeah.
Awesome. Great. Thank you so much, Jerrica. So much. You have such a wealth of knowledge, and truly so appreciative of you for being a part of this. Thank you for everybody else who had joined us. We hope you enjoyed yourselves. I know that there are so many different types of questions that we weren't able to answer. We literally had like 170 questions that were submitted. But so grateful for all of you. We hope to provide more of these webinars in the future. Again, our DMs are always open. We are always posting information like this on our Instagram at @getplume. And for folks that were interested in getting started here, we also had a lot of questions on how to get started. You can go to our website at getplume.co, which I will link this over here right now. You can go visit that website. You can get started. We're available in 33 different states, where we operate differently from some other endocrinologists because we come from an informed consent model. Who knows, maybe you will be you get to see Jerrica face to face during a doctor's appointment. You never know. But yeah, so that's it from us today. Look out, actually, so this is the end of our All About E week. If you're interested in All About T week, that is going to get started on Tuesday, the 22nd, we will have 2 panels, a community collaborator panel of folks who take testosterone, and then we will have another one of our own, Jasmine Price, who will help with our medical provider panel on that end too. So thank you very much. Hope you have a good rest of your night. Take care.
Thanks, everybody.